Yay. Okay, back to you, Jania.
Thank you so much, Rosa. Um, so I'm just going to give a heads up. I'm about to send through a PDF in the chat because some slides will be shown. But if you're the kind of person who prefers to look through things at your own pace or copy and paste things to look them up, a rather unfortunately large PDF will be coming your way. But basically, to give a quick rundown of the format, we're just going to go over some facts from the literature. And I say facts from the literature because I wouldn't say that these are necessarily absolute truths. But that's the point. The point is just to present some facts that are maybe commonly referenced or talked about, so that everyone can start at a sort of even playing field, so to speak, in the discussion. And then the last slide will have the questions for discussion. And at that point, I will share the creating space guidelines that we have for the network, just in case anybody would like to reference them. And hopefully most of today will be a nice interactive discussion. So without further ado, I will just share some slides. And I admit it's partially because I'm mainly a visual person. So if you are not, if you are prefer different senses, please do speak up if things are not working quite right. So the main topic of today, the diversity of chronic pain. And this came up in a conversation between myself, Rosa, and Bernie Carter. And part of it came from the fact that from my own lived experience in moving around different countries and cities, I found that people have different ways of approaching and understanding chronic pain. So then it was like, well, how do you have a discussion then if everyone has a very different understanding or a different experience? So I will just open up with this lovely definition from the International Classification of Diseases, which you may also have seen on the IASP website. And this definition of chronic pain is one that I think many people have seen in different pieces of medical literature or otherwise. And I think the key line in there is that they define chronic pain as pain that persists or recurs for longer than 3 months. That's very both definitive and quite open. And if you look more closely through the ICD-11, you will find that they actually have different subcategories of pain that they have also defined. And some of them are very specific, such as cancer-related pain, and then others seem to be a little more broad, such as neuropathic pain. So I just present this as a starting point for how chronic pain seems to be defined in the literature these days. Now, related to that, a term that might not be seen as much, but I think is sometimes hinted at in different pieces of literature, is high impact chronic pain. And here, this is from the IASP website, so the International Associate, I don't have my acronym quite right, but it's an international organization that on pain. And if someone happens to know the acronym properly, please feel free to add it in the chat. But basically, the main sort of important sentence here, at least to me, is that it talks about chronic pain that significantly impacts the affected person's daily life and functioning, such as work, socializing, and self-care. So far, this seems to already imply that chronic pain can be quite broad or exist on a sort of spectrum. Now, what's been interesting is that different categories of physical pain have also been evolving. And the terms on the left-hand side of the slide, nociceptive, neuropathic, nociplastic, the sort of more simplified explanation is in parentheses. So nociceptive, which is tissue injury, so like if your actual muscles get damaged or injured. Neuropathic, so nerve injury related, so if your nervous system is, well, not behaving quite right, I guess would be an oversimplified way of looking at it. Nociplastic seemed to show up in the past couple of years. So as you can see, this reference is from 2021. And I think the easiest way I can think of to give an example would be something like chronic fatigue syndrome or fibromyalgia. And I think what is also very nice is that these days there's an acknowledgement that you can have mixed pain. So it's not that you have only one type of pain or the other. It's possible and very much happens that someone might have a combination of different types of pain. Now, the common sources of chronic pain, I apologize. There was too many sources, plus people posting in forums about where of their lived experiences and what they had chronic pain from. So actually, this list is, I would say, far from exhaustive. I think perhaps something to note is that lower back pain is sometimes cited in certain articles as being the leading source of chronic pain. And then also lately, long COVID, I believe, has been getting some more attention in the wake of the pandemic. And then I think there's a few other examples where people might not normally think of associating with chronic pain. So for example, anxiety or depression, or maybe not taking something like their migraines seriously enough, when in fact, perhaps it is quite debilitating for someone. So I guess basically this is just to, where this all comes to is that remembering that chronic pain is not just a physical sensation, and that there are many other factors that might affect how someone experiences or defines their chronic pain. This table shows some of the factors in a very general way. So for example, age, gender, your ethnicity or your cultural background, your socioeconomic background, whether you can even work. And also perhaps important to note is that whereas in some pieces of literature, chronic pain can be defined as a disease by itself, other pieces of literature might identify chronic pain as a symptom of another condition. So then you might have a case where someone has several different health conditions and chronic pain is just sort of running across those multiple conditions. And then also, of course, did you grow up in an environment that acknowledges chronic pain? Or did you grow up in an environment where chronic pain does not exist? How does that shape your understanding of chronic pain? So I realize I've kind of zoomed through everything. Hence, again, in the PDF, you'll be able to see all the citations for yourselves if you wish to look for the article. I do encourage you to do so, because I feel like these articles have a lot of information that I really just glossed over for the sake of getting to the conversation. But I guess to me, there's some facts that I think are quite important when it comes to the concept of diversity. Because I wish to reiterate that in saying the diversity of chronic pain, it literally means diversity of any factors, but not just one specific factor or another, but just any factor that might affect chronic pain. So, for example, I was personally surprised to see a lot of articles citing chronic pain as the leading source of disability around the world. And it also seems interesting that the statistic for what percentage of the population is affected has such a wide range. Again, on the IASP website, I believe they use 20% as their statistic. I've seen 30% in another article, and then this one mentions 11% to 40%. So that's quite a big spread. So that, of course, then raises the question, how many people are actually being identified or even treated for their chronic pain. And then also perhaps of interest to some of you is the fact that certain demographics we know less about. So, for example, certain countries or certain ethnicities, they might not have come forward for treatment, and therefore were not included in any sort of study. Or there's been a lot of comparison studies between experiencing chronic pain as a male versus as a female. So that's another question. Who is being recognized as living with chronic pain? Who is getting treatment? Who isn't? Do they even know that they are living with chronic pain? So on that note, I'm just going to leave these questions up for a bit, and then I will also share them in the chat box. But basically, it's not that the discussion will happen, first on one question, and then the timer goes off, and then we switch to the next question. I would definitely say these questions are very interwoven with each other. But first of all, as a dance and somatic practitioner or a healthcare professional or any other type of specialist who works with individuals living with chronic pain, do you take into account these different factors when you are working with someone? Or do you feel that your practice can easily accommodate any type of chronic pain? For those who are living with chronic pain, do you think about how these factors affect your experience and approach to chronic pain? Perhaps whether it's your daily living habits or your how you choose to go get medical treatment or not get treatment. And then what are ways that dance and somatic practices already address the diversity of chronic pain? What could be done better? So again, these earlier facts were collected from a very narrow body of literature, so to speak. So are there different ways that are effective that maybe don't get as much attention that people know of, that people wish to share, things like that? So stop sharing my screen right now. And also, I would like to invite anybody else who's here from the network, if you would like to maybe chime in about perhaps how this has developed or how the network discussed these things already, please do feel free to do so.
I think I will say something about the work with the Roma community that I've observed, that our dance practice, because some of the families didn't speak English, so we would often have a Slovak or a Roma interpreter in the room. And when the families or some of the women, mainly it was women, who couldn't, let's say, find a word for the kind of pain or to describe the pain, it was when we danced together, moved together, or were breathing together that they could access some of that, or it would remind them where in the body that felt stronger. So that the dancing and our Roma dancing felt like an equalizer in the space. And when that landed, then we could appreciate that we each had a different body or a different way of feeling pain, but united in that we were kind of dancing together through our Roma dancing and through that tradition. So it was almost that the tradition allowed us to access and to have a conversation about pain, which was really beautiful, because that would shift the kind of way we worked in the future, or it allowed that relationship to develop, from here we are to talk about pain to here we are to be in a space and share together, and eventually get to this topic about pain and body and how that exists. So that's just an observation I offer.
I see a hand up from Jane.
Hi. Yeah, I'm a social prescriber working in the local community here in Knowsley, and I am somebody who also suffers from chronic pain. I have EDS, which is Ehlers-Danlos syndrome, which is a degenerative muscle condition for people who are just not aware of that acronym. And I find that I have a very unique perspective because chronic pain is so common within the people that I speak to as part of my social prescribing role. And what I find fascinating every time I have the conversation with people is people's surprise when I can understand the limits and the thought processes and the sort of challenges that people face when trying to explain and communicate their pain. And it gives me a really unique perspective, which is something that I'm actually grateful for with my own chronic pain journey. And it's allowed me to sort of value that a little bit differently. Whereas obviously chronic pain is often viewed as a negative because it hurts and it's a challenge. But it's allowed me to change that perspective slightly because of the joy that it actually brings to the people I work with when they can speak to somebody that actually understands.
I'll just chime in and I'll add that, yes, I feel much happier when I'm speaking to somebody who has lived experience as well. So that was really lovely to hear. And now it looks like Rebecca. Yes, please.
Hi everyone, it's nice to see you all. I'm quite new in terms of working with chronic pain in as a researcher. I do have some lived experience of chronic pain, but recently we've been looking at how we can use different arts-based methods to express the experience of chronic pain, and just based on just what has just been said, the idea of that lack of understanding that people have encountered in their everyday lives. So we brought together people with lived experience to as a community to find a sense of belonging, to talk, to kind of express through different methods, including kind of singing and dancing, what pain might look like, or the idea of pain narratives. And something that Rose was saying kind of resonated with me in terms of the role of breath within that work as a way of finding a sense of grounding or a sense of release. But we found that often, if we were starting with movement, then people would be quite scared to explore. Like if we thought about dance or thought about moving, then a lot of our participants, our lived experience experts, were encountered that kind of idea first with quite a lot of fear. But then as we were moving, or the approach that we took was ensuring everyone was working with their own body autonomy, their own individual experiences, and employing imagery quite a lot in encouraging, like not almost, so I haven't quite planned what I'm trying to say, but this idea of I like what Rosa said about the equalizing of experience as well, that everyone came with different experiences with movement and somatics, and recognizing that every contribution is fine. Yeah, so I don't quite know what I'm trying to say, but I'm just like, some of these things are resonating in terms of equalizing the role of the breath and looking after the individual experience and moving without almost having a preconception of what it means to dance or what it means to use the body in a creative way. Yeah.
Thank you, Emma, for the message in the chat. I'll read it out for ease, unless Emma wants to read it out. No, I'll read. Okay. Enjoying listening here so far. Lived experience as a way to offer peer support and support others to understand pain. The role of moving and breathing, being in a shared space together before you discuss pain. Yeah. So feel free to type and share things in the chat, and I'm happy to read. I'm monitoring the chat for us.
Thanks, Sarah. There's something.
Yeah, hi, I'm Sarah Hume. I'm actually a link worker as well, Jane. I'm social prescriber, and I've got lived experience of chronic pain. I've had a real flare up over the weekend, and I just feel like I'm not really getting anywhere with the NHS at the moment. I'm on a long waiting list, and I rang them yesterday. It turns out it's got even longer. So I was just Googling chronic pain. I thought I need to get some research, and then I found this webinar. So and just to reflect on what you've been saying about opening a space for someone to talk about chronic pain, I called the GP this morning and got an emergency appointment, and it just the difference of having a conversation with a GP to somebody that's a practitioner is just worlds apart. You know, he didn't even lay his hands on me and really check where the pain was. And I've had a significant flare up in my lower back, and he thinks it's nerve pain. But you know, it just didn't feel, there's probably not much he could have done, but I just didn't feel held in that space and particularly safe to come forward and say how I really felt. And it is affecting me emotionally because it's affecting my life. It's affecting the fact I can't really go and see people as much as I want to. I want to help my mum get a Christmas tree down, but actually that's probably not the job I can do because it hurts and it's the knock-on effect. And just for him to have a bit more of empathy would be nice, but I know it's in this world he's not able to offer that because it's a clinical setting. And I think I am seeking some sort of support from a practitioner, and I don't know what type is going to be right for me, but I just wanted to highlight that difference between what you've been saying about opening a space with creativity, art, movement, or the magic of life. Compare that to a GP appointment that feels very rushed and trying to get things off your chest. The good thing is he's going to try and get my I'm on waiting list for rheumatology and MSK, musculoskeletal. So he's going to try and get the waiting list position moved. So there is a positive from it, but I just wanted to share that experience, really. Thanks.
Me again, I think. I don't know whether my Wi-Fi will hold out coming in and out, so I don't know whether you can hear me properly. Okay, brilliant. Thanks, Rosa. Yeah, so I think that is a common problem with the GP and that sort of clinical approach, isn't it, to pain? And I was myself in a very, very similar position, and I was put on a medication called pregabalin, which obviously is a very strong painkiller. That was at the age of 32. And it's a very effective painkiller, and it is for a lot of people. Obviously, there's a lot of challenges and problems with it, as with many medications, but it does tend to be quite effective at the particular pain in which it's targeted at. But what I found, and a lot of other people found, that you had to sort of increase your dosage quite quickly. And I got to a point after like my third increase where I thought, hold on, I'm 32. What happens next? Where do I go at 35? Where do I go at 42, at 52, at 62? What are you going to give me? What can you give me? And it really frightened me. It really sort of brought it to the reality of, if I'm on this high level medication now and I have a degenerative condition, what happens next? And it was a real sort of awakening for me. And I'm from a very medical minded world. I had a mother with chronic rheumatoid arthritis who had 12 joint replacements, triple heart bypasses, that was being kept alive for probably 20 years by medicine. So, you know, my faith is absolutely in the medical model, and it always had been. And you know, if in my mind, in my world, if you were unwell, you went to see the GP, and that is how you got fixed. And that was how it worked. And it was a real moment of realization for me that potentially that there's other options. And it took me a long time to sort of get my head around that and look at a different perspective. And all in a matter of 6 months, I weaned myself off the pregabalin, under medical advice, obviously. I weaned myself off the pregabalin, started a weight loss journey. I hate that, because every time you go to a rheumatologist, they say to me, it's your weight. It's not my weight. It's not changed my pain. It's changed, the journey has changed the way in which I view my pain. The pain is not any different, because it's muscular. It's not pressure on joints that's the issue. And I also started to train. Now, I used to go to bed probably 5 nights out of 7 and cry myself to sleep because of the pain I was in. And now I'm training twice a day, every day. I know that's very extreme. And I wouldn't recommend that to anybody straight off, but that's just obviously my experience. And I actually, you know, I've been taking CBD oil for 18 months. And personally, obviously, I wouldn't ever make a recommendation to anybody about taking anything, but that's just my experience, and I've found that really, really beneficial. So it's really hard to take that shift from the medical model to looking at things a little bit differently, in my experience.
I just wanted to quickly add to what you said there. In our role, we're doing preventative work, aren't we? That's what social prescribers do and link workers. We're trying to prevent situations getting to crisis. So when you're in this job, it does open your mind, because my job is to try and reduce referrals into social workers, really, and then them needing to open a case for people that might need a care package. That's what I'm ultimately trying to reduce. And it's all about the preventative model. But then you can't help but, like you say, put that to your personal self. And my mum's very unwell herself and is on all sorts of medications. She's got all sorts of health complications. And that's how we were brought up. You go to the GP, that's where the answers are. But then as you open your mind more, and then you find out about, you know, the profit making in the pharmaceutical industry, like, we can't deny it, you know, the drive behind that. When you learn that stuff, you start waking up, and then you get back to nature and, you know, the organicness of life. And this job really opened my eyes up. And I just wanted to say I relate to you there, and I'm thinking about maybe going down the CBD road as well. Again, with a bit of apprehension there, but I've been doing my own research, and it feels like an empowered choice, not that somebody's then throwing it down my throat and saying, this is what you need to do, this is the only way. I'm trying to be open-minded. So I'm just really grateful that I'm here to hear your experience, Jane, and other people's, because it just takes an open-minded conversation and to think outside the box a little bit. Don't just go with the way the system kind of tells you to live. So yeah, thanks for sharing your experience, Jane. It resonates a lot.
Thank you both. I just wanted to interject real quick because I saw Bernie's hand up earlier. I just wanted to check in with Bernie really quick.
No, I was only going to make a really tiny comment, just saying that I think that having the space to be heard, wherever that is, whether or not that's kind of like traditional, kind of like GP or clinic type medicine or practitioners, is the thing that's absolutely core, because pain is such an isolating experience that it's really difficult to express or be given permission to express what you actually feel about pain, because you always want to try and present yourself as not a hopeless pain person or a failure or whatever. That side of that kind of stigmatizing way in which people with pain are often seen, completely incorrectly in my view, because I think that's a problem of perception rather than of actual experience. So I think that space where people could be heard is really, really important. And that, I don't think you necessarily have to be a practitioner or clinically trained. You have to be kind of like a companion to somebody or people in pain. And that can happen in lots of different places. And I think one of the ways where it's flowering is in kind of like arts-based, movement-based, breath-based practices, because people have the confidence to do those things there, take those steps. I should have said who I was right at the beginning. I'm sorry, I was just getting very excited. So, because it's really interesting conversation. I'm Bernie Carter, I'm part of the Somatic Practice Network, and I'm interested in chronic pain and advocate for children in chronic pain. And when, I'll stop in 2 seconds, but when Eugenia was talking about kind of like who we believe has got pain, there's definitely a hierarchy. And the more marginal you are, or the more vulnerable you are, or the more female you are, or the more child you are, the less likely you are to be believed by in kind of like traditional practice. And I'm somebody from traditional practice, from kind of like healthcare practice. And that's not belittling it, because there are brilliant, wonderful, amazing people in kind of like the NHS and with clinical backgrounds. It's just that they don't always have the space to create the space and to be with people. So I'll shut up then. But thank you everybody for the conversation.
I can't seem to put my hand up somehow. It seems to be missing from the choice. Just a couple of things. Pain is so problematic because it's both how the individual perceives and feels their pain and how they communicate it to someone else, and the fact that we have no way of measuring that pain. And I just want to say something that's starting here in Coventry. People will have heard of CBT, cognitive behavioural therapy in general practice. We're just starting a study of CFT, which is cognitive functional therapy. And it's a sort of similar approach. And we're focusing on chronic low back pain. I'm not a clinician, so I'm involved in the evaluation, but it's being led by physiotherapists in the university hospital locally. So it sort of acknowledges this body-mind interface. And I can see that synergies with dance. There are synergies with breathing, because there's an assumption that it's movement somehow that influences low back pain, but I think breath is part of it also. And I just wonder whether using dance with pain, whether anybody has looked at the interaction between people who are experiencing different pain but are dancing together. Do we know anything about that?
Do you mean like in a research kind of way? I mean, I just know anecdotally that, you know, with the Roma families that are women that I've engaged with, and we, you know, the Roma Pain Network, they all had different types of pain, different levels, different, I would say, even understanding of their pain. And there was a lot of taboo around their pain, because for Roma women, you know, it's to be strong, to be the head of the house, you know, that whole thing, that narrative was in the room. So to come together, just to even admit that there's a level of pain there, was huge, and that became, and the dancing and the breathing became the equalizer, and also a familiar space for us to connect and to reconnect with tradition. So there was a tension there about being a woman, a Roma woman, who felt very vulnerable and almost taboo to talk about this pain, but then so supported by the community, by a group of women coming together, and by our dancing. So yeah, that tension was certainly in the room. Now, I haven't written about that academically, and it's just there in kind of our work. But yeah, I see it, I felt it, I'm navigating it with them, alongside them. But no, that's not academically published anywhere.
It's sort of lived experience, and you know, CBT is normally used, it's targeted, say stop smoking or lose weight, but pain is not one thing. So if you have cognitive functional therapy that's targeting pain, do you just go for people who are experiencing pain in the same location, have the same diagnosis, or do you mix them? Is pain universal? Is it more to do whether it's continuous as opposed to intermittent? How do you, in order to, if this therapy is successful, how do you divide up the community of people living with pain who you would like to help?
I think all of what you've just asked is was one of the inspirations for this very discussion. Because, like, for example, I would say my pain journey has been more similar to like Sarah and Jane's respective journeys, trying to navigate different medical systems, trying to debate, am I going to rely on a certain medication? Do I feel comfortable increasing dosage? How long am I going to keep doing this? And it's interesting because I think when you're in a typical professional dance setting, a lot of people do talk about pain. They talk about their hip being, you know, out of whack, or their back hurting. But then what you hear less about is perhaps somebody who has an underlying condition that's also creating chronic pain. And I feel like the environments where I felt like it was safe to talk about chronic pain in a movement context was when it was not in a professional setting. So in a professional setting, it felt like, oh no, everyone's pain as a badge of honor. And I think Emma, I'm just going to call out Emma because I think Emma has a lot of experience on this topic. And yeah, it's strange because, for example, I feel a bit like an outlier in the somatic community because I rely on somatic practices in order to keep on moving, to even choreograph. But somatic practices do not necessarily ease my pain. In fact, I recently had to make the difficult decision to go back on a medication just to be able to do some of the somatic movement exercises, which was, I think, it's a little demoralizing sometimes, I think. So I'll just leave it at that. But yeah, I'm sorry, I'm just going to highlight that Emma might have some good observations in this area.
I'm aware of the chat, but I'll let Emma offer a reply, and then I'll read out the comments in the chat just to honor that voice and that side of the conversation. So Emma?
Thank you. Yeah, for the prompt, Eugenia. I've just been listening and taking notes and just really appreciating like the really diverse perspectives like in the room. And yeah, I'm trying to think about how to answer Ala's question. I don't really have an answer, but I think you know, there's various people have written about dance and movement and different kinds of chronic pain. Like Sylvie here, I know has written about fibromyalgia. And then in the kind of research, well, one piece that I've been doing is actually dancers who have chronic pain, but they actually make dance and choreographic work about their pain. So like, I think it was someone was mentioning earlier about, you know, it's almost turning its, you know, on its head. Okay, having chronic pain is not something I would have chosen, but I have it. And what do I do with it? And actually, how do I accept and celebrate the kind of movement I can do? Or like even sometimes people saying, well, I'm going to choose to dance and I know I'll be in pain afterwards, but that's a choice I'm making. So they had really different kinds of chronic pain and they chose to work with it in different ways. So I've been trying to write a little bit about that, which I thought was really interesting. And then I know myself and Bernie were writing something about somatic practices and how it can link with them pain management, you know, the ideas in pain management programs already, and things about developing confidence to move and things like that. But we also came across some challenges like the sensory challenges that Eugenia brought up earlier, because often with somatic practices, you might have sort of sensory awareness, but for some people that's just too challenging to heighten your sensory awareness because they already have challenges with touch or all sorts of sound, smells, all sorts of things, or perceiving their body in space. So I think there's a lot more work to be done. Yeah, I don't know, there might be other people who want to talk about their work as well, what they've found. Yeah, I think Emily is, oh, and Rosa was going to say something as well. Sorry.
Yeah, Emily, feel free, and I'll after people have spoken, then I'll read the chat. But I'm just very mindful of the chat. So if you've been writing in the chat, I am aware of it. I haven't forgotten it. Emily, yeah.
Thank you. Hi. Yeah, I'm so sorry I was late joining the session, but I've really enjoyed just jumping in, picking up and hearing what you've been talking about. So I'm coming from, I'm a singing for health practitioner and researcher and have focused quite a lot of my work on pain management. And yes, we say singing, but actually the program that we've developed is very much around movement, breath work, relaxation. You know, it's not just singing, that kind of simplifies it too much. But just on the kind of categorization, what we found through our work and research is that we've actually now separated people with MSK pain and fibromyalgia. So we've got kind of two, and this is all very, very kind of experience driven as well as research driven, in that our approach is it's very nuanced. You know, it's very, I couldn't probably tell you exactly, well, some of it I can, but the approach is different. We work differently with people with fibromyalgia to MSK. So that's kind of the line that we've gone down, and we're working with our NHS Trust, and we're working with the pain clinic, and we've actually devised a kind of an alternative pain management program which complements the statutory pain management program, but incorporates a lot of this kind of, you know, using the voice, using breath, using movement, using sound healing as well. So we're going to be delivering that as a research feasibility project in Cornwall. I'm based in Cornwall, by the way. So it's been really interesting, and I think what we found is that obviously we're just working with a small number of people really. I can't say that this is true of the population, but our experience is that people with fibromyalgia tend to have more comorbidities, and there tends to be a lot more kind of going on for them in terms of mental health. That's just what we found through our work. But yeah, it's been quite interesting to go on that journey of making those decisions in terms of our pedagogy and the way that we deliver the sessions, that we noticed that there was a difference with fibromyalgia. So that's the approach that we've taken in Cornwall. Don't know if that helps. Yes, Noya.
Yes, hi, thank you. Thank you very much. It's an amazing conversation. And thank you, Emma, for inviting me. So I'm from the University of Winchester. I'm dance lecturer and somatic practitioner, but I'm also a newly craniosacral therapist. And I'm just trying to bridge those two practices and two approaches to the body and to trauma and to therapy in general. And I wanted to come back on one of the comments on oh, sorry, it's getting long. Something around the fear of using the body. So the thing that I have experience is that often people that have chronic pain, including myself, you have then the fear of moving. And there's that kind of borderline between, especially if you have had some dance experience before where you know it could be good for you, it will be good for you, but then it hurts, and the memory of the pain become part of the narrative that you're telling yourself or telling, who you're talking to in terms of conversation with a therapist, for instance. So the realization that actually you can move with less pain or around the pain, and that the verbal, I think at the beginning of the conversation we talked a lot about being able to express how does the pain feel like, the fear of the pain come against that self-expression, and sometimes it's been really helpful to find ways of coming into the body, but that also can trigger pain with some of the people that I work with, and then it goes into that dissociation with the body. So my research is at the moment is around that. How do I work around those kind of boundaries of trying to come to a body that is a painful body. And the work on breath, that has been mentioned before, has been really helpful, but not always. And I guess that's coming back to there are different people. We're all differently experiencing pain. But I guess what I wanted to offer is that the state of dissociation or the state of dissociationing of our body can sometimes make it harder to come to the body through movement, especially when movement is painful. But it's also coming back to the way that we will talk about our pain and the narrative around pain, and how we can repatterning the way that we talk about our pain and owning it through movement. Thank you.
Yeah. And Ross?
Hi everybody. Yeah, I'm Ross. I'm a physiotherapist by background, but I've worked in university now, sort of research and teaching the last 10 years, and I'm part of the Somatic Practice Chronic Pain Network. I think it's really interesting, like listening to the different points that people are making, because obviously I've seen it from my physio perspective when I've had chronic pain patients come and see me. And so I think it was Sarah was saying about her GP experience, and and you know, the fact that he didn't touch you, or he didn't put his hands on you or something on the pain point. And I think that's a lot of part of the sort of almost like a teaching that, you know, GPs perhaps receive about not wanting to how could we say, really highlight the pain area, and not trying to put too much of a perspective on it, which again I think is probably a lot to do with the time factors. I think it's interesting as well to hear people talking about various studies that they're involved with, because I think really you know, chronic pain is something that's increasing in prevalence. There's no doubt about it. So part of me thinks that obviously means that some of the strategies that we have perhaps aren't working. So I really think that there's a need to be open-minded about what we do going forward. So I think, you know, any strategies that can get people moving, you know, dance-related strategies, for example, I think are a great idea, because I think it's the fear of movement that can develop over a period of time that really harms people. And I think also as well, it's the different aspects of pain, isn't there? You know, it's like, what exactly is chronic pain? I know there's like the definition of, you know, so many months worth of pain. But, you know, I always think that some of the definitions, they're not as helpful, because it's such an individual thing. And even like the type of pain, like what is the type of pain that someone feels? You know, is it a dull pain? Is it a sharp pain? So yeah, I think it's really interesting to hear what people are doing, because I definitely like to sort of link up with people from here, because I think you know, sometimes you can be a bit isolated, I think, in your work if you don't realize quite what others are doing. So yeah, that's it. That's all I've got to say.
Thank you both. And I'm wondering, maybe Rosa, do you want to?
Yes, I'm mindful of the time, but the chat has been very lively. We had Sylvie suggest earlier, Nalia Kuhlman will begin in January a research project about the potential of immersive technologies to convey bodily and felt, for example, embodied experiences of people with Parkinson's. I am part of it as a collaborator, so please do reach out. Emma made a few notes about the NHS waiting list, quality of conversations with healthcare professionals, empathy, and medication preventative work, and making empowered choices. Jane was reflecting on things that she hears in her. You always want to present as being okay. When I tell other people that I used to cry in bed most nights with pain, they would say, really? You would never know. Thank you for sharing that personal experience. Sarah was thanking Bernie. Sylvie, there was asked Allah, how could we know more about CFT? So if you would, maybe you've put that in the chat. There are a lot of messages here. I don't know if and images, and maybe I'll see if I can save the chat for everyone, because I'm mindful of time. So that might be tricky if I just read through. But if there's anything that anyone's put in the chat that they would like to share, reflect. I see Tanya has a hand up. Yes, Tanya. Tanya, would you like to say or share? Yes.
Sorry about that. I was having a technical glitch. Hi, yes, my name's Tanya Douglas. I actually work on a pain programme within the NHS. So it's been really fascinating listening to a lot of the conversation that's been you've been having, and I kind of feel like I should vaguely apologise for the waiting lists, but clearly I'd like to say it has nothing to do with me. But it's been really useful to hear what people have said, and it's really highlighted some components that we really see with the programmes that we run. There's been a lot of conversation here around communication and people listening, and definitely with the programs that we run 2 and 3 week pain management programs, and a big component of it is always about the peer support and the networks, and people always when they complete questionnaires and we have focus groups involving the patients that we've seen, they always talk about the support group with the people that they have met who've also been on the program at the same time, and how they keep in touch with those people forever. They're actually as important, if not more important, than the practitioners who are working as part of the program, really. So that communication and that network is really important for individuals. And I think it's a big part of what people have talked about feeling listened to, sharing experiences. So that I was just going to pick up on that, but also around people have talked about the medical model, and moving away from that medical model that we've all grown up with, that you have pain, therefore there is physical peripheral pain, and we need to have medication to get rid of that pain, and how a big part of moving across to a CBT approach, or potentially a CFT approach, which is a new one on me, so I'm looking forward to hearing about that, is being in that place where you're ready to move on, and it's kind of almost going through the psychology of a grieving process, of being able to being in the right place to then move on to accepting a different kind of model of care, which is very much around goal setting and targets and activity. And I suppose then that comes on a bit with the activity and the breathing that people have talked about, that for some people we include kind of Tai Chi and physical exercise as part of our program, so that incorporates the breathing and the activity, but so much of it is around the individual's goals and what they want to get back to. And for a lot of people it's not necessarily physical activity, but we do know the psychological benefits and the physical benefits of doing activity, and so trying to draw people into finding something that works for them. So the opportunity to dance, to sing, some of the creative activities that people might have never chosen before are fantastic. And so I would really highlight on any opportunities for people to be able to reach out to groups to join activities that they've never participated in before, but that might really support them, would be hugely beneficial. So the work that I've heard people talking about, and the singing and the dancing, is fantastic. If people are not already interested in that, and that's not already their thing, and that's not what they're trying to set goals to get back to, the opportunity for them to find something new and experience that sounds hugely beneficial. So thank you to those people who are involved in that. So anyway, so that's just my take on what you've said, and it's been really interesting listening to everybody, so thank you.
Just a quick response to Rose's question. Emma could ask one or two of the therapists to come and talk, say, in a few months' time about cognitive functional therapy, because that study is just getting ethics approval at the moment. But I think there's sort of intersectionality. It's people who are physiotherapists, but they're moving into a different space. And many of the things that Tanya has said are just part and parcel of what would be. It's a way of chronic pain is very different, and it's how you live with it, manage it, how you minimize the impact on your life. So, if the group were interested, I'm sure that Emma could arrange that, say, in a few months' time. And I think the people involved would find it interesting to have an audience like this query what they're doing and what their experiences are.
So I just want to say we have about 10 more minutes left in the discussion. If there's anybody who has a burning thought or comment or question? Emma?
I had a question, probably most relevant for the people with lived experience of chronic pain, about, you know, self-management. Because I was wondering if that creates a pressure to always be doing something to help your pain, that then creates more stress, which is then not good for your pain, if you know what I mean. So like, yeah, I just was curious about that, like, because then there's a to-do list. Well, I must do that, and I must do that, and I must do that. And then, you know, kind of the stress of keeping all the balls in the air, trying to self-manage. So that question kind of came up for me from the discussion as well. Like, it just feels like a lot of pressure, and how do you kind of deal with that? So that was something I was curious about.
I'll say something. I get pain every now and then, for quite horrible, and it probably meets the criteria for chronic pain, but I'm pretty darn lucky as I'm pain free some of the time as well. So I've got nothing to kind of like moan about. And it's not all consuming like some people's chronic pain is. So that way I am lucky. At the British Pain Society special interest group on the ethics and philosophy of pain last year, there was a 2 or 3 day meeting about kind of like arts based and less kind of more innovative ways of actually managing pain. And one of the speakers, Tim, was talking about how at one point his management of his pain became a full-time job, and it was consuming him almost as much as the pain was consuming him. And he was spending as much time working on his pain management and trying to get everything right, that he didn't actually have any time left over for anything else, including work or family or friends or anything. So, and he couldn't almost see past that. And then there was a point at which he kind of thought, a little bit like somebody was saying earlier on about the tailing off, kind of like the medication, because if they couldn't quite see where they were going to go in the future with it. And he started not exactly to relax, but he started to accommodate things. And he'd gone from sort of like, I'm going to try this, I'm going to try this, I'm going to try this, I'm going to try this. And then if something that had worked, like cold water swimming, didn't work, that then became kind of like a massive failure. And he then didn't know whether or not he could trust cold water swimming again. And then he kind of, like I say, I'm not sure relaxed is the word that he would use, but he accommodated both the self-management and the pain into his life. So that it wasn't always great and it wasn't always awful, but it was still a sort of work that had to be done. And I don't know if that kind of, and that was really interesting. And a lot of the clinicians that were there, and most of the people that were there were active clinicians who were really passionate and compassionate people trying to do their best for people in all sorts of different types of chronic pain. That kind of really switch light bulbs onto them, because quite often I think self-management is put into the hands of the person and becomes kind of their responsibility. And that's a big thing when you're already dealing with a life and pain and work and children and caring and God knows what else. So that was just a thought.
Noelle, did you wish to say something? I saw you earlier.
Oh yes, I'm actually not muted. Oh gosh. Yeah, I just wanted to say I totally agree with what Bernie said as well. But the also that sometimes the nature of chronic pain is that it changes as well sometimes. So then you try something and it works for a while and then it doesn't work anymore. The pain has changed somewhere else. So it feels like that the change kind of force you to always be proactive, always have to try something different. And then on the other hand, I also kind of meet people that feel they don't do enough. So the stress is reversed because they feel like they should be doing more things as well. Or yeah, so it's a different it's definitely something about lifestyle choices as well. And it but the nature of chronic pain and that idea of that you need to always adapt to a new sensation of pain seems to be something that I've encountered a lot as well.
Sarah?
Just to sort of follow on from both, really, when Tanya said the self-management pressure, sort of a light bulb went off, and I think that's something I've been reflecting on recently. Is it then feel it's more on your to-do list almost, and I'm fortunate enough to be in full-time work at the moment, but then when you've then got to in your lunch hour try and incorporate your movement, your stretches, you're getting your fresh air, getting your daylight, all the self-care habits, it's sort of become this mental checklist that you've then got to do. And if you've not reached certain goals and done your breath work in the morning, you're then feeling like a failure. But then if you actually stop and take a minute, you think, well, actually I didn't have time because of this, or I struggled to get up this morning, my fatigue was bad. But it takes a lot of work to keep checking in with yourself, and sometimes I do feel a bit envious of people that are sort of just getting on with things, but then you've got to remember everyone's got something going on. But I think for me, it's sometimes not knowing what I should be doing. I think if I knew the right thing that was working, I'll do it. But I think because I've not had my rheumatology appointment or my MSK one, haven't been given recommendations for my diagnosis. So I've got long COVID, but I also potentially have fibromyalgia as well, and I've got costochondritis, inflammation, all sorts of stuff. Without having those specific recommendations, it's just leaving me with a lot of fear. And I keep getting told by people, well, if you do strength training or you do movement, then it's got to get worse before it gets better, right? And I just keep feeling this pressure to start lifting weights, or if that's going to help me build strength. But I'm just so fearful of taking that next step that, yes, the self-management might be difficult, but at least if I know what's actually working for me, I'll feel less pressure when I succeed at it, and it might actually make a difference. So yeah, it's just really interesting to hear everyone's perspective, and just take a lot from everything everyone said. I'm just going to be a bit more patient with myself, I think. So thank you.
Thank you. I just wanted to add in real quick, because I suddenly remembered something that a dance artist in the UK, Raquel Messager said. And that was having the confidence or assertiveness, I don't know, but basically the ability to advocate for oneself, especially when one is not visibly the image of chronic pain. So, it could be because of age, it could be because of weight, it could be because you have all your limbs and you're able to stand. Maybe you can still, do triple pirouettes, but nobody sees that the next day you can't get out of bed. I find that socially, that advocating for one's needs is particularly difficult when you don't fit the image of what people expect a chronically ill or a person with chronic pain to look like. And I just wanted to mention that in Singapore, they have something very interesting here. They have like this little yellow card you can apply for, and you wear it on a lanyard. And what that does is, if you need assistance with public transportation or you need a seat, technically, I've not seen it in action yet, but technically you should be able to show the card. And so regardless of what you look like, or regardless of any other demographic factor, if you have that yellow card, it's supposed to signal to everyone else that, please, let this person have an accommodation. And then, sorry, Allah.
No, I was just going to ask a bit, because I'm lucky I don't have pain, I don't have chronic pain. But one of the real issues for researchers is actually demonstrating that something works. So with self-management, I mean, and if it's intermittent, if it's not constant, as Bernie was saying, how do you as individuals living with pain know that something has worked or is working? I can understand deprescribing and you reduce your medication and you can then sort of see whether there's a relationship. But for other things, you know, which may be movement, breath, how do you know? Because all we can do is we ask people on the various pain questionnaires, you know, where does your pain lie? There's sort of functionality questionnaires, can you do this, that, or the other? But how does an individual living with pain know whether something has worked?
For me, it was being able to wear a bra for longer than a few minutes. At the moment, I'm struggling to wear one, which isn't great because I'll be honest, I do have big breasts, and it's very uncomfortable in a working environment having to now wear a bra in the office, whereas at home I have that flexibility. But then there was a period of time where it didn't hurt as much when I was wearing one, and I was like, right, what I'm doing is working at the moment. But then I've had a relapse recently where I'm having a lot of pain, and it's also affecting my breathing. I'm really shallow breathing at the moment, and I can feel like it's like somebody's been like tying up my rib cage almost, and it feels really, really tight at the moment and really sore. So that's just an observation of how I would notice. It's by sometimes the clothes you wear. If you can, there's days where there's certain dresses with like straps on that I could wear and it would just set it off, and then other days that dress is fine. So yeah, from my perspective.
Just anecdotally, we used to run our sessions on a Thursday, and one of the participants said, "Great, Thursdays is my baking day because after we do the session, I actually feel so much better. I can stand in the kitchen and do my baking. And any other day, I can't. I'm so debilitated by my pain, I can't. But after our sessions, I go and do baking." So she did baking Thursdays. And then we had other people say that, you know, they employed some of the techniques that we were doing in the sessions, that they use them in their lives and were able to do things for longer, where, you know, really noticed that they were able to cook themselves a meal without being in pain, or go for a walk, or go and see a friend, you know, things that they just couldn't have considered doing before. So for us, those are really powerful messages and impacts. And those are the ones I think that when I present to medical professionals, yes, they want the kind of the research and the, you know, all of that sort of stuff, but actually it's the individual stories, I think sometimes that just really do matter, and really people really do take note of that, because, you know, we're all human, aren't we? We can all relate to those human experiences. So I think it's important to highlight these anecdotal examples.
I'm just going to jump in here because, well, we have a very nice segue. But as we wrap up, I just want to highlight one person who has provided an exercise for me that for a glorious 5 minutes, I didn't feel any pain. Literally nothingness. And that person is Alina Keith, who is another member of the network. And she's going to actually be offering a movement session fairly soon on December 7th. So just speaking of different ways to see if is it working or not, I am personally endorsing the exercises that she offers, because it is very rare for me to have that moment of nothingness, so to speak. So as I hate to have to wrap everything up, but since we're close on time, I believe Emma's got a feedback form that she's been sharing with everybody, but perhaps, I don't know, Emma, do you wish to speak a little more about it?
Yeah, so one of the things with the network, we initially had funding and myself and Bernie were running it. And the funding is finished up now. So we've tried to keep the activities going without funding with a board. Some of the board members are here with Rosa, Ala and Eugenia as well as Bernie. And but what really helps is getting feedback. So in the university, they like to know that this work is having some impact or it's relevant to people. That helps me to kind of get time to keep it going. And it also is really interesting for us to understand what is helpful for people and what's not. And so I put it's very short link in the chat there. If you can scroll up, I can paste it again. And I've also put the flyer for Alina's movement snack, which is next week. And I'll put the link in there as well. She has the Zoom link in on her website. So it's like 15 minutes to join in, move gently. You can have your camera on or off and just join us for a few minutes of moving together. Thanks. And thanks so much, Rosa and Eugenia, for coming up with the idea for this webinar and hosting it, because Amy and I thought the discussion was really good today, and thanks everyone for pitching in and sharing all our different perspectives as well. So thank you.
Yes, thank you, everybody. And also I want to say thank you to Bernie as well for seeding the whole idea. That's the best way I can put it. She planted the seed. So yes, I don't know if anybody has a final last thought they wish to share, either out loud or in the chat. But yes, if anyone does have something they wish to say, please do.
Just thank you very much. And my parking is running out, so I have to leave. Thank you.
Yeah.
Thank you, everyone. I will try to save the chats, and we have the recording. And then for those that didn't hear my message at the beginning, if after reflecting on the conversation today, you realize actually what I shared, I don't want that to be publicly available, we can then figure out if we edit that out or if the whole recording just stays private. But we can see and discuss. So do let myself know or anyone from the network know. And thank you everyone.
Oh, and if anyone has websites or publications or any such materials that they would like to share, like if you happen to not remember it right this minute, but later you're like, oh, yes, please do let us know. Please do send it in. I think there was a lot of really wonderful information. So.
Thank you. Bye.
Yeah.